Fighting Blindness Canada's View Point education series shares the latest in vision research, provides opportunities for you to ask your questions, and connect with other people who are living with a blinding eye disease. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by our Platinum partner Bayer and supported by our Gold partner Roche and Silver partners AbbVie, Astellas, Beacon Therapeutics, Johnson & Johnson, and Specsavers. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
Yeah, I'm going to get started because we always have more questions than we can answer. Oh, Jamie's saying I'm not talking loud enough. If we're not talking loud enough, just wave your hand and we're going to do better. So I'm really happy to have on stage Dr. Matt Benson. He is a clinician scientist in the Department of Ophthalmology at the University of Alberta, and he holds the Bayer Professorship in Translational Research in Ophthalmology. After completing his residency and graduate studies at the University of Alberta, he trained in ocular genetics at the NIH, and his clinical interests include inherited eye diseases and strabismus, and his research focuses on inherited retinal disorders. And we've heard the name Dr. Ian McDonald a few times in the room. He trained with Dr. Ian McDonald, so he's the new Ian McDonald, I think, in Alberta. So I'm sure you're all going to get to know him well. So, I always like to start off these sessions with a few questions for myself, just to make sure, especially if anybody is new to a diagnosis, new to inherited retinal diseases, we all get a little bit of information to level set us. But we will have lots of room for questions, so get ready, and if you have a question that you can't wait, just put your hand up and we'll get the Q&A started early. So first of all, I'm using the term inherited retinal diseases. I was wondering, Matt, if you could tell us a little bit more about what an inherited retinal disease is.
Yes, for sure. Thanks, Larissa, and thanks everyone for being here too. We'll make sure we have lots of time to answer your questions. So an inherited retinal disease you might hear called an IRD is the abbreviation. It's basically a retinal condition that's genetic. It doesn't necessarily mean that, like inherited retinal disease generally, inherited implies that it came from another generation usually, but the genetic retinal disorders could just affect one individual in a family. And so I kind of think of an IRD as a genetic disorder of the retina, but you may just be the only person in the family, or you may have a family history of the condition. It can affect patients at really any age, from birth up until the elderly age. And so it's quite a wide range of conditions, and some of them can affect more than just the eye as well. They can affect hearing, they can affect your kidneys or balance. Maybe about a third of the time they can have some other extraocular involvement. And so that's basically a general overview, but you'll hear the term IRD referred to a genetic condition of the retina.
Thank you. And you sort of mentioned it as oh, thank you, Jamie. I also want to say hi to all of our people who are joining us across Canada on the live stream, and so we'll also get to your questions as well. So don't worry, we're not going to forget about you. So you mentioned there are different types of inherited retinal diseases. They can impact people in different ways. I was wondering if you could talk a little bit more about that diversity. So how many types of inherited retinal diseases are there? How are they similar? How are they different? Are there some things in common across most of them?
Yeah, that's a great question. So they're very diverse. When we do genetic testing in the clinic, we usually check for about 350 genes that can cause these conditions, but maybe about a handful of them cause the more common types of IRDs that we see in the clinic. And so it's a range of presentations. Some patients are even unaware they have the condition until they go to an eye doctor and they notice some changes in the back of their eyes. Other patients may have difficulties with their central vision and they're not able to read something as clearly as they used to be able to. And say they go to their optometrist and they try to get glasses to fix that and they're not able to get better vision. That may be one of the early signs of a problem in the central part of the back of the eye. And then other patients may have difficulties with their nighttime vision or peripheral vision issues, and sometimes a combination of these. And some of the inherited retinal diseases progress a little bit more quickly than others, and some conditions that are from birth especially don't necessarily progress, and they're relatively stationary. So there's quite a wide range of presentations.
You mentioned that inherited retinal diseases is caused by a genetic mutation or a genetic change. Can you talk a little bit more about how that genetic change might impact how your disease exists or how it progresses?
Yeah, so we all have different changes in our DNA. A lot of them are just add to the variability and make us who we are, but then there's certain changes that can potentially impact the function of a protein. And different mutations can have different severities of effects as well. Some genetic conditions, the retina or IRDs, they have a particular type of mutation that generally tends to cause the problem. And so if you have a mutation that leads to no protein being produced, for example, that generally would have a severe effect. There are obviously some examples where that might not be the case, but different types of mutations can have different types of effects on that gene and on that protein product, and that also influences the variability that we see too. So you may hear about some of the genes like RPGR is a common one, or USH2A, or RPE65. And even patients that have these conditions, and even within the same family, their presentation can be quite variable, even if they have the same change. But if they have different changes, that also adds to the variability of these conditions.
So there's the genetic component, but is there also then an environmental component or other things that can impact it if somebody with the same mutation can have different presentations?
Yeah, exactly. And I don't think we really understand all that builds into that variability, but certainly the genetic aspect is one. There's also a term, I don't want to get too technical, but epigenetic, which is where there are changes, not necessarily at the gene level, but at the gene regulation level that can also influence it also influences the variability of the phenotype. And then there's environmental factors as well. Some of these we don't necessarily understand, but we know things like smoking could potentially make retinal conditions worse. Not necessarily in all cases, but we generally advise patients to avoid things like smoking. And then something that we recommend kind of from a dietary supplementation standpoint is omega-3 fatty acids, which are generally helpful for retinal health overall. So there are certain factors that are environmental that definitely can make things worse, but we still are learning about these conditions, and we don't know everything that adds to the variability.
Just to sort of finish off with this conversation about sort of genetics and genetic testing, can you explain a little bit about how somebody would get a diagnosis of an inherited retinal disease and the process they might go through?
Yeah, for sure. And this is sort of coming at it from the physician side, but I'm sure members in the audience will have experiences with this too. So in my experience, it kind of depends on if the genetic diagnosis was originally suspected. So some patients will come to me and they'll have family members that have, say, retinitis pigmentosa, and they saw an optometrist or another eye care provider who suspected they may have something similar. And so some of those patients are caught at a little bit of an earlier stage because of this family history. But then there are other patients that maybe have subtle findings or findings that the eye care provider is unaware of, or they don't know, what that necessarily means, and it can be a long lead time before they reach a diagnosis. But generally, a retina specialist, sometimes a comprehensive ophthalmologist, will be the first person to suspect that it's an inherited retinal disease. And then they're often sent to somebody like myself or Ian MacDonald to offer the genetic testing alongside with a genetic counselor. And so what that process involves is usually a saliva sample, or we take kind of a sample from inside the cheek. The DNA is extracted from those cells and sent to a lab where we check for changes in genes that cause inherited retinal diseases. And the turnaround time for the genetic testing is usually a few months, depending upon the type of genetic testing that we're doing. And we are lucky to work with genetic counselors who explain the implications of genetic testing as well, because there are factors to consider with providing your sample for genetic testing as well.
Okay, thank you. I'm just going to ask one more question before I'm seeing if there's some questions in the audience. And this is a pretty broad one. So much of what Fighting Blindness Canada talks about is research and research to find new treatments. And I know that specifically in the inherited retinal disease space, there really are very few treatments. The only one is Luxturna, which is for specifically, as you mentioned, for people who have the RPE65 mutation. And that's a gene therapy. I was wondering if you could talk a little bit more about the sort of different types of potential therapies out there, since there aren't too many right now, and sort of where you're seeing some of the exciting things happening?
Right, yeah, so there's, and I always think back to maybe 10, 15 years ago, we were more so just focused on gene therapies. Now there's kind of a broad range of approaches to try to help patients with IRDs. Gene therapy is one, and even within gene therapy, there's a lot of different kind of examples of how they're trying to change either the genetic code or give back a missing gene. So for Luxturna, I'll just kind of go into that for members of the audience who are less familiar. But like Larissa mentioned, that's a specific therapy for patients that have changes in the RPE65 gene. And we've treated several patients in Edmonton who have this condition. Usually results in severe vision loss from an early age. Sometimes it can present more like retinitis pigmentosa as well at a later age. So we've treated several patients, and what that therapy involves is a gene replacement. So it means giving back a normal copy, because patients generally have mutations that lead to the loss of that protein. And so it requires a surgical procedure where the gel or the vitreous in the eye is removed, and then the gene copy is delivered underneath the retina using kind of an inactivated virus. And this same approach is being used for a number of other inherited retinal diseases as well, and a large number of them are in clinical trials at various phases. RPGR is one disorder that affects predominantly males, but sometimes females as well. That's also far along in clinical trials in phase 3, and it's using the same approach with a subretinal gene replacement therapy. And there's also gene editing. This is using a term called CRISPR, which some of you may have heard about. And the idea there is you're actually correcting the spelling mistake in the genetic code. Generally, that involves the same approach where you'd have a surgery, the gel's removed from the eye, and then the CRISPR components are added using a virus, an inactivated virus, also delivered underneath the retina. So several conditions like CEP290 and a few others are looking at this sort of approach. And there's also a genetic therapy that is on the RNA level, so not the DNA level. So sort of one step downstream from that, where you're using specific molecules to block elements that you don't necessarily want to be there. So if a patient has a mutation, for example, that is in a region that's not so important in the protein but's causing a problem, you can block that, that mutation using a separate kind of approach that usually involves an injection of medicine into the eye. So this is a different kind of way of treating conditions that would generally require multiple injections, sort of like patients with wet macular degeneration would need. And that's kind of, in general, the genetic therapies. There's also small molecule therapies, which are basically oral medications that patients would take. The idea there is that it would slow down the progression of conditions and potentially boost a little bit of the vision, but by and large, the oral therapies are mainly designed to slow down progression. And so there are a few oral therapies being studied for RP and then also for Stargardt disease. So you may have heard of N-acetylcysteine. This is an antioxidant that's being used in very high doses for patients with retinitis pigmentosa. One of the advantages is we're in this kind of era where it's very precision medicine based, so we're looking at treatments for very specific genes and even very specific changes in the genes. But what I think is exciting is broadening that inquiry and looking at approaches, say like an acetylcysteine, which would be something that multiple patients could benefit from and doesn't necessarily depend on having a specific change in a specific gene. So they call that gene agnostic approaches, where it's a treatment that could benefit a large number of patients and it doesn't necessarily depend on what specific mutation a patient has. And then there's also stem cell therapies, which Dr. Lamba will get into. And these are, I'm less familiar than he is about these, but these are also exciting, and there's lots of progress being made in this space. The idea is that in certain patients who have kind of later stages of retinal degeneration, they don't necessarily have the correct cells in place to accept a gene therapy. And so for these, this category of conditions, it requires a different approach, which is replacing the cells that are missing. And that's what stem cell therapies are looking at. And from my understanding, they're in the early phases of clinical trials at the moment. I don't think there's a phase 3 study just yet. So those are a little bit further behind the gene therapies, but also very important and interesting progress is being made there too.
Thank you, Matt. And it was really interesting to hear that you have been involved in treating some patients with the first gene therapy. Have you seen sort of the impact of the gene therapy? What was sort of the impact for some of your patients?
Yeah, so I'll be speaking a bit indirectly because they're patients of Dr. Ian McDonald, and so I've just kind of heard about how some of them have done. But I believe there's 7 patients that have been treated in Edmonton, not all from Alberta, because we are one of, I think, a handful of sites across Canada that are delivering the therapy. So I think there are a few patients from Saskatchewan and even Nova Scotia as well. And it seems like overall it's positive. Not everyone benefits the same degree that we would hope. And just anecdotally, it seems that the younger patients potentially do a little bit better, and I think that has to do with them having a lesser degree of retinal degeneration, and potentially the retinas are more amenable to this therapy. So with gene therapies in general, the earlier the better in terms of treatment. And so I think that's reflected in the patients that we've treated as well.
Okay, thank you. I can keep asking questions, but I'm going to actually open it up to the audience, because this is the point of the session, is to really allow the audience to ask whatever questions you have on your mind for Dr. Benson. So if you have a question, please put your hand up, and Jamie will come by with a microphone. Do we have any questions from the audience?
Hello, can you hear me okay? Thank you, Dr. Benson, for being here. My name is Mike McFadden. I've inherited retinal disease from my mother's side, and she's 85 years old and legally blind now, but independent, living in Sherwood Park. My 2 older siblings have been done the genetic testing and are diagnosed with a similar inherited retinal disease along with myself. And then I had my children tested, and it is not present. But I guess my question is, IRD is a pretty general term, and I have this condition. It's called retinal fleck dystrophy, and then I've got a big series of letters and numbers that quantify this, I guess, C1QTNF5. So I still am a little confused on, is this retinosis pigmentosa? Is this Lords? Is this an IRD? What is there more specific? I guess that is the specific description of it, but is there somewhere in between so that when I'm trying to follow advancements in technology and treatment and preventative measures, that I'm looking at the right thing?
Yeah, it's a really good question, and I think it's something that even the field is struggling with, because probably your and your family's condition would have been described as like retinal degeneration for a long time, and it's really a non-specific term, and not all forms of retinal degeneration necessarily are even caused by like a genetic cause, for example. And so in your particular family's case, I would probably it wouldn't really be listed as retinitis pigmentosa, because that gene causes more, like you're mentioning, it's called LORD, or late onset retinal degeneration. So I'd probably just if you're looking at kind of research, trying to follow the research and seeing what sort of therapies are being developed that are not necessarily specific for that gene, but might be still something that you'd be interested in. I think just keeping it broad and looking at inherited retinal disease, or IRDs, when you're thinking about staying on top of the research. But within the field, though, we're trying to stick to more of like a gene-based term for a specific condition, because as you're saying, they're all very different. And so for the C1q TNF5, that would be what we would classify it like as an inherited disease specialist in the clinic, or as late onset retinal degeneration, because that term is just caused by that gene. But that's not to say that if you're looking at research opportunities and what's coming out in the future, I think keeping it broad would be good, because very likely things like N-acetylcysteine, if it's approved, would be worth trying in your family's case as well, and you'd want to kind of keep on top of that research as well.
Great, thank you. I have one more question, actually, just on the preventative side, good health. I mean, taking care of yourself, rest, vitamins, protection from the sun, etc. Is there anything else besides the omega-3? I take the Vital-X or an eye supplement, but is there anything else that you would recommend that might help slow the onset of the disease?
Yeah, so I think it's good that you're taking the omega-3s. I'll just kind of just make a note that they're not necessarily studied in a way that we know they would slow down the condition, slow down retinal disorders, but it's just a large chunk of the retina is made up of omega-3 fatty acids, and so we feel it's good to supplement and make sure that you're not deficient in those, but it's not been specifically shown to slow down progression, but we generally recommend it as an overall measure to promote retinal health. One thing I'll say about Vitalux, actually, and this came up relatively recently, is I think in your case it's a little bit of a gray area, but I would say in patients with retinitis pigmentosa, which is a bit different than what your family has, the AREDS vitamins, so that was the age-related eye disease study. There's AREDS 2 formula that's specifically for patients with macular degeneration in the intermediate form or advanced form of macular degeneration. The idea is that you take these supplements, I think it's usually twice a day, and it slows down the progression of AMD. Those supplements contain vitamin E, and the vitamin E is in the same dose that they found in a study years ago when they looked back at how patients with RP did over time. They thought that maybe vitamin E might be helpful, and they found that it's harmful for some patients with RP. So usually, if a patient has been diagnosed with retinitis pigmentosa, we usually counsel against taking AREDS vitamins or those eye multivitamins because of the vitamin E component. But your family's diagnosis is a bit different than retinitis pigmentosa, so it's hard to say in your case. So I don't think, yeah, almost the late onset retinal degeneration looks more like macular degeneration, so I don't think that's necessarily a problem. But for patients with RP, we generally suggest now with very recent data that it's best to avoid the Vitalux or PreserVision.
Can I just follow up on that? We get a lot of questions about vitamins, or is there anything from a nutrition point of view that somebody can do? So is there any other advice you would give to your patients? And in addition to, say, AREDS and vitamin E, is there anything else that people should be avoiding if they have different types of inherited retinal diseases?
Right, yeah, so vitamin A is something that comes up. Years ago in the 90s, there was a clinical trial where they looked at patients with retinitis pigmentosa randomized to very high doses of vitamin A. I think it was around 15,000 international units, which is very, very high, so far higher than what you'd get just from kind of eating carrots or having a regular diet. And there was evidence that on one of the functional tests, which some of you in the audience may have had this electric test where they put these kind of wires around the eyes, they put you in the dark for 20 minutes in the light and shine these different flashes of light. They found that one of those measures was declined at a slower rate in patients that were taking very high doses of vitamin A. And so we felt like for a long time that it might be a good idea to take very high doses of vitamin A if you have retinitis pigmentosa. And so some of you may have been on that or have been recommended that. But now that we have the genetic information from those patients that participate in that study, we found that some of the patients or the people that did the study, when they looked back at the results, they found that some patients actually did worse when they were on high dose of vitamin A if they had certain genetic changes. And so it's something we don't recommend any longer. It also can impact the liver and affect other body systems. And so very high dose of vitamin A for RP is usually not something that we would recommend. And then for patients in the audience or patients that may have Stargardt disease, this is a condition where vitamin A byproducts build up in the retina. And so we think that excess vitamin A is not such a good thing. And so that's another condition that we would recommend not supplementing with vitamin A. But you don't need to avoid eating, carrots and being too careful about what you eat. It's mainly just don't take very high or extra supplement. Don't supplement with vitamin A, basically, if you have Stargardt disease. And then the caveat to all of this, too, is that we talked about the AREDS vitamins. Those are the ones that have the vitamin E. They also have vitamin A derivatives, but they're not metabolized in the same way. And we don't know if the tablets or the Vitalux that patients take for macular degeneration would be helpful for Stargardt disease patients or not, but it's not something I counsel patients not to take because it's not the same type of vitamin A. So if someone had Stargardt disease and they wanted to take Vitalux, I don't think it would be a problem, but we usually recommend for those patients with RP or retinitis pigmentosa to avoid taking Vitalux.
Okay, there's a lot of different nuances there depending on exactly what eye disease you have. So I guess definitely talk to your retinal specialists before taking high doses of any vitamin, I think is the sort of take-home message here. Are there any other questions from the audience? We've got one right in the front.
I should have this question because we have been doing this for years. But if you're diagnosed with, say, our son has cone rod dystrophy, is the diagnosis, but there's never been a gene identified. Difficult to get testing done. Only way we've been able to have testing done in the last few years is because his sister has an autoinflammatory condition. So then they look at the whole family. But how do we know that it is actually a genetic condition if no one has it and there's no gene identified?
Right, it's a good point. And for the inherited retinal diseases, which cone rod dystrophy falls within that, probably about 70% of the time we do genetic testing, we can identify exactly what the problem is. But that leaves about 30% of the time where we don't have an answer for the family in terms of the specific mutation or variant. But still, though, we think that most of those cases are still inherited. If it presents at an early age, it's affecting both eyes, it's relatively symmetric, and that the ERG, that electric test, shows evidence of cone and rod dysfunction. It very likely is genetic. We just haven't been able to find exactly what the change is that's causing it. There's a few reasons why patients fall into that category of kind of an unsolved genetic case. Some of the time, it's just that we don't know all of the genes that contribute to these conditions. That maybe explains a small percent now, because it seems like the era of gene discovery, we've kind of made a lot of advances in terms of finding genes that cause specific conditions. And I think probably more where the issue lies in these unsolved cases is that there's changes in regions of the gene that's difficult to sequence and pick up on the testing we do. So I think it's important that if this testing was done, say, a few years ago, there would potentially be an opportunity to retest the family in the next few years, because the sequencing technologies do evolve, and there's a chance we might be able to pick up what wouldn't have been able to be detected years ago. So it's still helpful to maintain that relationship with whoever originally did the testing, because we'll often indicate that in our letters as well, as if a patient had a negative result, to reach out to the same genetic counselor or a retina specialist and ask for testing again in about 3 or 5 years. That's usually a time in which the technologies have evolved, and there's a good chance we might be able to pick up what's going on.
I was going to say, I didn't actually realize that about the technological challenges of sequencing. I'd always thought it was, we don't know the genes yet. Not that actually, it doesn't always, you're not able to sequence the genes, so thank you. While we go to the back, before that, I'm just going to ask one question from the live stream. So there was somebody who asked if they could learn more about oligocomb trichromacy.
That's a really good question. So oligocone trichromacy, it's an inherited retinal disorder, although we don't know exactly what the gene is that causes it, to my knowledge. And so it's an area that I'm a little bit less familiar with, but where I trained at the National Eye Institute, there were a few individuals there who were studying it. So if somebody was interested in learning more about it, it's not something I have very much experience with, but I could put them in touch with someone who would be able to hopefully answer some of their questions on that.
Okay, and I think that's a good sort of segue to say, if at the end of the session you think of more questions, or if we weren't able to get to your questions, we have a health information line where you can either email or call in to ask questions, and we can, I personally don't know about oligochrome trichromacy, but I can pass on information to Dr. Benson or other experts to get some more information, and we'll share that information in a follow-up email as well. And I think Ushani's typing it into the chat if you're on the live stream right now. So right at the back.
Thank you so much, Dr. Benson, for your information. It was very helpful. I just have a really two-part question. When I was young, our family was, I was told I have macular degeneration. It was the early 80s, and then it came in years and years after having my own family and having a daughter, and researching it ended up being a wrong diagnosis, and now she's got cone rod dystrophy, and they think we have cone rod dystrophy, and they've isolated the gene. And the short and the long of it is, when we were young, after the initial visit, we didn't go to ophthalmology. We didn't see eye care clinicians, and as my daughter grew, I made sure she did. Now she's 22 and does not want to go to the eye doctor anymore, and I can't blame her. Could you please tell me what a responsible amount of time to visit an eye care clinician is, and what are the pros and cons of going?
Yeah, that's a really fair question, and it's something that I often think about in the clinic too, because like as you know, that we unfortunately don't have treatments for the vast majority of inherited retinal diseases. I usually will still see patients every year or two in the clinic, mainly to make sure they're not developing other eye problems. Some of them, such as say cataracts, glaucoma, things that patients would be at risk of with age, for example, or other family history that are not necessarily related to a cone rod dystrophy. But if someone was in their 20s and didn't have an inherited retinal disease, they wouldn't necessarily have to see someone for monitoring for those conditions. So maybe if she saw an ophthalmologist every few years would be reasonable, unless she had a problem that came up. Because I think that would still give enough time that if there were any therapies that became available, that she's at least connected with the research as well, and she can ask those questions during her appointment. But probably every few years I think would be okay. Yeah, every year ideally, but I appreciate that every few years is probably okay.
And just as a follow-up to that, are most of your patients, are they being followed, if not by you, by an ophthalmologist or by a community optometrist, or both? Either is okay.
Yeah, I think it depends. And most patients are seen by an optometrist because they often have a need for glasses, and most ophthalmologists nowadays, some of them do prescribe glasses, but a lot of them don't. And so often patients are connected with an optometrist. And if they didn't have any other eye issues and they're just seeing, say, someone like myself, then I think seeing an optometrist would be fine. And then seeing someone like myself or a retina specialist every few years would be okay, unless there's something that came up that warranted a more urgent appointment.
Thank you. Are there any other questions in the room? I see one back there.
Hi, just following up on those 2 points. I see my optometrist annually, and she uses a technology called the OptoMap to look at the retina. Just can you comment on how valuable that is?
Yeah, that's a really good question. So the OptoMap is a feature of a fundus camera called the Optos, and it's a very helpful fundus camera that we're trying to get at the Royal Alex Hospital. Actually, most retina clinics, like private centers, will have that. Basically, you can take a picture of the back of someone's eye. They don't even necessarily need to be dilated, and you get a very wide picture of someone's retina. And you can use special filters to look at kind of a black and white image that more easily shows you how things are progressing over time. So I think it's helpful. The one thing, though, is I'm not an optometrist. I don't want to kind of speak on their behalf, but I think that I know that some optometrists do charge for that specific photo, and I don't from my perspective. I don't know if it's necessary to have that every year, but there may be specific things they're monitoring. So I wouldn't want to make that kind of a statement across the board. But if you were to go to an ophthalmologist's office and they did have that camera, they probably would take the picture, but it generally wouldn't be charged to the patient, though. So there's a little bit of kind of that element to it as well. But I would say if you've had a condition that's been slowly changing over time, you don't necessarily need to have images of it every single year unless something has changed.
Thank you. Are there any other questions from the room at this moment? Or while people are thinking of them, I'm going to ask another question that came in through our live stream. The question is, are there any strategies in place to link patients early on to potential inherited retinal disease interventions across Canada? I think that means clinical trials or new treatments, so that people can avoid missing out on treatment opportunities.
Yes, definitely. So there's a couple of different ways people can stay informed. One of them is through Fighting Blindness Canada's website. They have a clinical trials section, which I personally find is very helpful because even for me, it's very difficult to stay on top of all of the trials that are ongoing. It seems like every few weeks there's something new, and FBC website stays relatively up to date, and it's broken down by specific conditions such as Usher syndrome, RP, Stargardt disease, and so you can see a list of the ongoing clinical trials, how far along they are, and there's links to the websites as well for those companies. So I found that to be really helpful. There's also a website called clinicaltrials.gov. This is run by the US. Some of you may be familiar with it. It's a little bit more difficult to navigate. They basically have clinical trials for all sorts of medical issues. Not all of them are necessarily vetted by an ethics board as well, and so you would want to still discuss whatever you're interested in from your clinicaltrials.gov search with your eye care provider, because they're a little bit difficult to navigate, and they might not necessarily be relevant to, like the ones that sound like they're relevant, they may not necessarily be in your best interest. So it's good to still run that by your eye care provider.
And I would say something to consider, and Matt, Dr. Benson runs this in Alberta, is there's a patient registry, and the Alberta site is run by Dr. Benson. And so if you have an inherited retinal disease, you can talk to Dr. Benson about registering through the registry, and then if clinical trials are coming, especially if they're coming in Alberta, that would be a way to get contacted more quickly for clinical trials or new treatments. Because this was something I didn't know when I started the job. A lot of medical records that the hospitals keep, they don't necessarily have a space for a clinical diagnosis like retinitis pigmentosa or the gene name. So it's really, really hard to actually find patients who might meet certain eligibility criteria without a separate list. So that's the power of the registry. I see a question over there. Go ahead, Ruan.
Hi, I'm Ruan. I'm living with retinitis pigmentosa, and I have 2 kids who are asymptomatic. So my question is, what are the current recommendations or considerations for genetic testing of children whose parents, 1 or 2, have an IRD, whether they should or should not get genetic testing?
Yeah, it's a really important question, and I guess it would depend on what type of RP it is, because sometimes a patient might have retinitis pigmentosa that's recessive, and then that generally means that they have 2 changes in a particular gene, like one that was inherited from each parent. And so if someone has a recessive form of retinitis pigmentosa, then we would anticipate their kids to be carriers, but would unlikely be affected. But if someone has a dominant form, which means that they inherited it in a 50-50 chance, then their children would have a 50-50 chance of inheriting it too. So it depends a little bit on what the specific type of RP it is. But for testing asymptomatic minors in general, in the medical genetics community, we generally shy away from that unless they're developing symptoms or until they reach an age where they can make the decision themselves about testing. But we definitely have still tested some children who are asymptomatic, and the family's well aware of the diagnosis. We just kind of approach on a case-by-case basis because we're just kind of hesitant that kids are treated differently because they may develop, because even within, like we were chatting about earlier, like there's lots of variability in presentations too, and so even if one member of the family experienced disease a certain way, their children, if they're going to develop it, may not present that same way too. So we're just really hesitant to put a label on someone that has no symptoms because we don't necessarily know the degree to which they may be affected too. But there certainly are cases where we have done testing, but as a whole, we generally tend to avoid doing that and allow the patient to make that decision when they're older.
Okay. I think we've got time for about one more quick question. Is there any other questions in the room? I was going to say your last chance, but it isn't, because Dr. Benson will stick around for a few minutes. So at the break, you're welcome to come up and ask your questions in person if you didn't want to ask them out here. Okay, and I think this is a great time to wrap it up. So let's thank Dr. Benson. Thank you so much for coming.